Abnormalities. And so we're going to go over a correlation with our ultrasound findings and connect them with the prenatal screening results. And so let's take a look at the agenda. So can everyone see the bullet points on the agenda listed?
Yes, we can.
Okay.
Yes.
All right. All right. So starting, we're going to go over just a quick intro to prenatal ultrasound, which is just a quick refresher. And then we'll link that to understanding chromosomal disorders. Now, from there, we'll discuss prenatal screening, unveiling the connection with the ultrasound and the chromosomal disorders that we'll be discussing. And we're going to bridge the gap between our ultrasound findings and how we can help in the diagnosis that we're finding on the prenatal screenings. And from there, my favorite part is where the future is headed. How are we enhancing our skills, our ultrasound findings with the advancements from our ultrasound machine? So that'll be the final thought here. Okay, so let's get started. Let's go to the intro to prenatal ultrasound. Now, this will be just a quick refresher. What is the point? What is the purpose of doing the scans during pregnancy? I feel like it's the forefront of the pregnancy. It's vital. It's especially vital in helping monitor the fetal health and development throughout the entire pregnancy. And from there, we can see the birth defects. Without getting the actual visual inside, how will we know if the fetus is forming properly? And so it helps with recognizing these birth defects. And from there, it helped guide management decisions for the healthcare provider, as well as offering reassurance for the parents. So it's just, everyone likes seeing their baby on the scan. So it helps with the bonding too with the parents as well. So that's the purpose and the importance of prenatal ultrasound. Now, what are the different ultrasounds that are offered during the pregnancy? First and foremost is your standard 2D ultrasound. A lot of my patients, I don't know for you all, but a lot of my patients think that 3D would eventually take the place of 2D ultrasound. And I'm like, no, standardly, you have to look at the fetus with the 2D ultrasound, and 3D and 4D and 5D is just an enhancement of the 2D ultrasound. I don't think that it will take the place of a 2D ultrasound, but it just enhances what we see by 2D. Now, from there, Doppler ultrasound helps in just showing us the circulation of the blood flow between the fetus and placenta. So that's another vital ultrasound that's offered during prenatal care. Okay. All right. So let's get into the breakdown of chromosomal disorders. What actually is it? How is it characterized? And so aneuploidy is the most prevalent chromosomal disorder, and is simply characterized by an abnormal number of chromosomes. Now, we know that there's several. I just listed like the four main ones here. So we have Down syndrome, Turner syndrome, Edwards syndrome, and Patel. Now, we're going to talk about a few others as we go on, but these are like the pretty most commonly mentioned chromosomal disorders that you will hear during like a prenatal care. Okay. All right. Now, how does the chromosome disorder um, form? And when you think about it, when I was reading this and I was like, how can I explain this? So think about like a birth defect or even like a heart defect. Usually there is an error that happens during embryology. Something went wrong during early development, and that's what caused an issue. So in the case of a chromosomal disorder, the non-destruction is the process that led to this genetic issue. And simply put, the chromosomes fail to separate. And that's what happens in the case of a chromosomal disorder. So, in the normal process, they should divide equally, but there's an imbalance that goes wrong with this non-disjunction process, and it causes this error to happen. So that's why a chromosomal disorder is formed. Okay. All right. Now, there is some risk factors for having this non-disjunction process to happen, and it's usually in the case of mothers that's over 35. And so that is why a lot of these prenatal screening tests that we're about to talk about is offered to these moms because there's a higher chance of a chromosomal issue of happening. And why is that? Naturally, as we get older, unfortunately, as we get older, these mutations automatically happens. And so there's an imbalance with our egg quality, and it can increase the chance of having a chromosomal disorder. Now, if you add in the fact that you may have a family history, you have to take that into consideration as well. If you have a history of Down syndrome, maybe a few generations or so, it's really helpful to still, as a patient, as they add that into their patient work and so forth, to list that because it could just predispose that patient of having a chromosomal disorder. So it's important to take that family history into consideration as well. And also, early detection is extremely important. And I find as we're discussing about these prenatal screenings, a lot of these are offered like early on, 9 weeks, before you can even see these ultrasound markers. And so these prenatal screenings are becoming really helpful with these diagnoses. Okay. All right, so let's get into this. We're getting to the fun part. We're going to unveil the connection of the chromosomal disorder. So let's take a closer look. All right. Now, with the integration with prenatal screenings, I would say probably in the last maybe like 5 to 8 years, I feel like prenatal screenings are really taking the forefront in the prenatal care. And why is that? Well, we see that with these prenatal screenings, they're really aiding and helping in identifying these chromosomal disorders, so as I mentioned, pretty early. And so they're becoming the forefront of prenatal care, especially for those high risk populations. So with this integrated approach, we're able to get an early identifier of these chromosomal issues. Another reason for this integration of the screenings is when our ultrasound findings are ambiguous. A lot of times we're scanning and we're like, I don't quite know what's happening here. These prenatal screenings, when combined with our findings, are becoming very helpful in these diagnoses. And then from there, the healthcare provider is able to do a personalized care plan. If we see markers for our scans during our scans and it correlates with the screening results, then you're able to maybe the doctor is able to maybe offer an invasive testing just so the patient can know for sure. So it's really becoming a combination tool to use during prenatal care. Okay, it's really becoming important to say. Now, there is some pros and cons when with the prenatal screenings. Now, first and foremost, they're non-invasive. So there is no harm to mom or to the fetus. And so that's, I would say that's a plus with these prenatal screenings. Once again, I mentioned before, it's an early risk identification for these birth defects early on. You can offer better preparation for birth and a possibility of pre and post birth treatment if it's needed. Now, some of the cons, unfortunately, with these prenatal screenings is that it doesn't give a definitive diagnosis, unfortunately. It's just a risk of. And so, in that case, it can cause anxiety for the patient. And so it's just really that's why I created this webinar only because it's noticing the markers that you see with ultrasound and correlating with the screening will help relieve some of this anxiety. for the patients. And so we're going to kind of go over these ultrasound markers. Okay. All right. Now, just to break down, I don't know if everyone's familiar with all the prenatal screening testings that are offered, but these are a few that I feel like are commonly seen, starting with the carrier testing. That is usually done prior to pregnancy, but a lot of times, some patients, once they find out they're pregnant, they will do a carrier testing. And that, a lot of times, the mom will do it, but if she's positive for anything, then dad will also do a carrier testing to see if they match or so forth. So, carrier testing is offered. You have the first trimester screening. That's done between 10 to 13 weeks. And that's a component of your blood test and your NT ultrasound. So that's like your first trimester with the nuchal translucency. Now, the integrated and sequential screening timing is between 10 to 22 weeks. And that's a combined method of multiple screenings. But its purpose, as you see, it's Down syndrome, trisomy 13, 18. And with the integrated and sequential screening, it's also for neural tube defects. Okay. Now, a lot of the cell free DNA screening, this one is really offered to a lot of our patients, even our low risk patients. A lot of times our patients say the gender test because with this one it tells you gender, but of course we know it's not just for gender. It's for the Down syndrome, the trisomies, and then as well as the sex chromosome disorders. And then lastly, the quad screen. I feel like this is the old school one. We usually, this was around for way before these other testings were involved. And this is done later on, in between the 15 to 22 weeks. And that's your standard neural tube defects to, detect for the spina bifida. Okay. Now let's take a step further. With these testings, a lot of these testings will look into the hormones from mom and the placenta. And so we're going to break down why. What is the purpose of that? Those hormones really, really tell us a lot, actually. And so if you look here on your right, there's the three hormones. You have your HCG, your estrol, and your inhibin A. Now, and AFP as well. So don't forget AFP. But when you think about HCG, a lot of times you're like, oh, that's just the pregnancy hormone, or it's increased because of multiple gestation. But not so. It's also increased with trisomy 21. And so that's why it's helpful to know the value in the HCG. And in cases where it's decreased, it could be significant for trisomy 18. Okay, so it's not just for just a pregnancy hormone. Now, to go back up to the AFP, AFP also could be associated with trisomy 21 as well as trisomy 18. As is mentioned here, low levels are usually associated with those syndromes. Now, when you look at estrol, once again, abnormally low levels is associated with the trisomy 18 and trisomy 21. And then for inhibin A, extremely elevated levels is associated with trisomy 21. So these hormones tells a lot of information when in relating to the chromosomal disorders. Very helpful. Now with that, I created a chart because it's one thing when you look, and we just went over that and it's just like, that doesn't make sense to me. But when you see here on the chart, pretty much with these hormones, everything um, is low besides in cases of the HCG, which we mentioned, will be elevated for trisomy 21, as well as the high inhibin A is also elevated. But everything else, as you see, it's pretty standardly low. And then in cases for triploidy, it will have extremely, extremely, extremely high levels of HCG associated. Okay, so when you look at it in a chart format, it's easy to remember this. I actually have a copy of this on my LinkedIn page, but if anyone wants a copy of that, of this here, just let me know and I can email it to them. Okay. All right. So let's take a look at when a patient receives a risk, a prenatal screening risk. This is an example of what the result looks like. Now, look at the top where it has Down syndrome, the screening risk, 1 in 4,300. And then, but before the screening, notice at the maternal age, it was 1 in 830. I just wanted to point that out. Okay. Now, in the case for trisomy 18, it was a less than 1 in 10,000 chance mentioned. And then once again, you see the hormones listed below. Okay. So I just wanted you to see a representation of a prenatal screening result and how it looks for the patient when it comes back. Okay. So as you see, everything was negative. All right. Now, from there, what are some of the roles of having additional diagnostic tests? Why would a provider recommend an amniocentesis or a CVS, a more invasive testing? And typically, the invasive tests aren't offered unless there is a strong correlation of ultrasound findings and a positive screening result. And so we're going to actually look at some examples, some cases that I've had. But usually, that's what I've seen, where the additional diagnostic tests will be offered in those sort of settings. Okay, so let's talk about a CVS. I've been lucky enough to be able to assist in a few successful ones. And so a CVS, let's break down what is a CVS. So a CVS is the timing of a CVS is pretty early on. So you will do a CVS in the first trimester. Here it's mentioned 10 to 13 weeks. It is done earlier. And so once again, it's in a case of like a positive or a high family history risk. Usually a patient will go through this early testing. Now you'll get quick results compared to an amniocentesis. And it is a definitive diagnosis in this particular case. Now, there is some cons for a CVS, unfortunately. The neural tube limitations aren't picked up with this testing. There is a slight elevated miscarriage risk for the patient. I had a patient tell me after her one of her CVSs, she had a placenta abruption and lost the fetus, unfortunately. So there is a risk of that with a CVS. Here it mentioned that it's also a small risk of limb defects from this testing as well. So it's an invasive test, the CVS. Okay. Now looking at an amniocentesis is offered a little later. Now, this is usually done after 16 weeks. And because usually from the method of introducing the needle within the gestational sac, you need the amnion to be fused. And we know that is not fused until after the 16-week mark. And so that's the reasoning behind that. Now, some of the pros for amniocentesis, it can detect the neural tube defects. Okay. It has a higher accuracy. Okay, that's good. And it will confirm a CVS results. I've never seen, not to say that it hasn't happened, but I've never seen where a patient did a CVS and then follow up with an amnio. But in cases where, okay, they want to know for sure, uh, this amnio it can confirm CVS results. The miscarriage risk is lower than a CVS testing. And then also with amnio, it can detect the RH incompatibility. Okay, so it has a lot of pros here. Now the cons is it is later. So it's performed later in pregnancy, a lot of times closer to the 5 month mark. And so that will have a delay in diagnosing. The fewer cells are collected, so it possibly can extend the result time. And so it's not as fast as the CVS results. And then once again, with an invasive test, complications may apply, and so you may have a risk of miscarriage and so forth. So you still carry on that risk in this case. Okay? But you'll have a definitive diagnosis. I do want to point that out as well. Now this is a very interesting case. I don't know, prior to this particular patient, I had personally never heard of trisomy 8. And so you're about to see, we had a patient that was positive for both trisomy 8 and trisomy 10. And so before I talked about the case study, I wanted you guys to just see what exactly it is. So trisomy 8 is a condition where it appears that only some of the cells carry the extra chromosome, often resulting in some ultrasound findings. Now, with trisomy 8, some of the markers will include a thickened neck, a small jaw, and other possible anomalies. And so it's not a lot of markers that I could found associated with trisomy 8, but trisomy 10, as you see here, had a few more. So when you combine the risk of the trisomy 8 and trisomy 10, you see it also results in an increase in T, micronathia, renal agenesis, it's pretty serious there, and facial clefts. The limb, you can see in this particular case, there is a shorter arm, so you can see that, and other key features. So with the combined risk of this patient having both, it was a big deal. We wanted to know for sure, is does this fetus really have that? Now the she offered to do a further testing, which I want to show you her results. So this is the screening test that came back. Take a look at that. Now look at where down the bottom, 13, 18, and 21, all three of those were negative. But you see, she had that positive risk or increased risk for trisomy 10 and 8. And so, I mean, if you think about it, the patient was really the anxiety level was really there, because she's like, oh my goodness, I'm not only increased for one trisomy but two, with the same kind of ultrasound markers which we're seeing. So of course there was anxiety. She did not want to do the CVS, only due to that, as we mentioned, those birth defects. And so she did do the amniocentesis, and long and behold, her results were normal. So in this particular case, I our markers didn't quite match with the screening results, and so amniocentesis was normal. And believe it or not, the thickened neck or nuchal fold resolved. The arm was actually okay. It was just like a shorter humerus bone, but everything ended up being fine, which matched with the amniocentesis results. There were no complications from the amniocentesis, and she should be well in her third trimester. Okay, so this was a happy, successful case in this particular one, where everything ended up being okay. Okay. All right. So now we're going to look at some of those ultrasound markers that I mentioned earlier. And so before we break down markers that are seen in each chromosome disorder, we're going to just talk about what is markers. What is that? Personally like markers because I feel like, as is mentioned here, they're clues into what the diagnosis is. Not that we're diagnosing, but it helps in presenting your case to the doctor, and they're able to look at that and say, oh, this looks like it could potentially be trisomy 21. But let's take a step further. Okay. So some commonly seen markers, which I'm sure everyone has seen this, is first and foremost a thickened NT, nuchal fold, echogenic bowel, renal pylectasis, absent nasal bone, and two vessel cord. Okay. Now, a lot of times when you see them isolated, they're not as scary, I guess you can say. But when you see them in combination with each other, that's when it's really a red flag. It suggests a higher risk for the chromosomal disorders. And so you want to take a closer look. Okay. Now let's break down these markers in each chromosome. This is where that notepad will come into play, just so you're able to see the correlation of what you will see on ultrasound with each particular chromosome disorder. Okay, now we're going to start with our very first one, which is the most common chromosomal disorder, and that's trisomy 21. Now, what's over in the corner, what you're seeing here is what you will see from an amniocentesis result, and what's usually flagged, which you can see the trisomy 21 there with the arrow. Okay, so I just wanted to point that out. Now, some of the common ultrasound markers that are seen, of course, is the absent nasal bone, clyndectoly, duodenal atresia. Usually I don't see double bubble until later on, closer to the third trimester in these cases. EIF, which is the echogenic focus in the heart, hypercoic bowel, macroglossia. You'll have some mild ventriculomegaly, non-immune hydrops, a thickened nuchal fold. Let me see. Oh, sandal gap is one that's commonly seen, pylectasis, shortened limbs, and a VSD. And also, lastly, the widened pelvic bones. Okay, so these are all pretty standard ultrasound markers related to Down syndrome. Now, let's take a step further in cases of, so say, like, for instance, especially when I'm doing a first trimester screening and we're going through and I notice that there is an increase in T and then followed by a absent nasal bone. I've even seen pylectasis with my first trimester scans. And so in that case, I'm going to say let's take a look at a ductus venosus waveform. Let's see what the ductus venosus, how does it present itself. So in a normal setting, your A wave should be above the baseline. But in the cases of a trisomy 21, it's either going to be reversed. So the A wave will be below the baseline or absent. Okay. And if you notice in my header, approximately 80% of T21 fetuses will present with an abnormal ductus venosus. Okay, so just when you see those other findings and then you see an abnormal ductus venosus, you can like, oh, okay, this is looking like a trisomy 21 fetus. Okay, so here's an example. Remember those markers we just discussed. Here is a patient who presents as a positive NIPT for trisomy 21. Okay, as you see in the first picture, absent nasal bone. You can see there, no nasal bone is present. There is a thickened nuchal, okay, followed by absent A wave. In this case, we see echogenic bowel, also VSD, and shortened limbs. So you can almost, once we saw these markers, we were like, okay, this definitely matches up with trisomy 21. So of course the doctor uh, consulted the patient. They did want an amniocentesis, and the amniocentesis did confirm that it was trisomy 21. Okay, so you see the correlation there for sure. Okay, now let's take a look at trisomy 18. Okay, so once again, I do want to point out where we can see the three here. This is from the amniocentesis. So 3 copies of the chromosome 18. Now with trisomy 18, the markers that are seen are the strawberry-shaped skull, agenesis of the corpus callosum, CP cyst, so the choreplexus cyst, pretty standard. Also the clench hands, overlapping finger. Again, VSD is also seen with this one. The low set ears, micronathia, hydrocephalus. Another thing that's not mentioned, the feet, and feet either whether it's rocker bottom or club foot, those are commonly seen. These fetuses will also have some sort of renal anomaly that could extreme from pylectasis to agenesis or so forth, and two vessel cord. Okay. Also, I want to mention once again with the levels of the hormones, you see low levels of AFP, estrol, HCG, and PAPA. Okay. Second most common trisomy, and it's usually lethal. Now, I do want to point out one that I recently just saw. This particular fetus screening result came back positive for trisomy 18. Now, remember the markers we just went through. Okay, so right away we see a thickened nucleus. It's sort of like septated cystic hygroma. You can see. Look at the arm here on the left. You can see the bullet of the arm. And two vessel cord was confirmed as well. We can see here in phallicil. Okay. I don't know if you can see the time in. Looks like it was about, this was pretty early on, 11 weeks, 6 days. Okay. So these findings you can see pretty early. So it matched with the risk, the screening risk for the patient, T18, and it was diagnosed or confirmed with an invasive procedure, and it was T18 in that case, in this case as well. Okay. Okay, you can see here. Now, earlier I was showing I didn't have a copy of the amnio results for the other chromosome, but here is an example of the T18 that came back for this particular case where it was flagged. Now notice, if you remember in the screening result, how it just say increased risk, but with your amnio results, it's a definitive diagnosis. And so it says abnormal female trisomy 18. So it's a definitive diagnosis. All right, so this was from the FISH results of the amnio. Okay, now with trisomy 13, you have the 3 copies of the chromosome 13. This is another one that's usually lethal within the first year of life. A lot of markers are mentioned here. Ones that I've commonly seen in trisomy 13 is the microcephaly. I've seen the polydactyly, proencephaly almost always in the cases that I've seen, cleft lip as well, two vessel cord, let me see, and club feet are usually some of the common markers that I've seen personally with trisomy 13. Okay. Now let's go to Turner syndrome. Turner syndrome is where it's always female. With this particular case, almost always a cystic hygroma is commonly seen with this one, followed by a coarctation or hypoplastic left is usually seen with Turner syndrome. Now, I want to show you an example of a positive screening result. I hope you can see it. It's here on the left. Patient was flagged for having a positive result for Turner's. In this particular case, yes, we did see the cystic hygroma. We didn't quite see a heart defect. A lot of times with coarctations, it may present itself later, but patient did have that cystic hygroma. And so followed by the screening result, we did do an amniocentesis, which you can see in the interpretation, female with Turner syndrome. So it was confirmed. Okay, it was confirmed. All right. So just to take a step further, I believe it's two more left. Triploidy. Triploidy presents itself differently. The ultrasound findings in the first trimester versus the second and third trimester. Once again, the HCG levels are extremely elevated in these cases. I've never seen a triploidy. So I feel like it may be pretty rare, but and just in case, if you so happen to run across it, it may present itself as a partial molar pregnancy in the first trimester, followed by those bilateral ovarian thecan lutein cysts. So the ovaries are extremely large, and unfortunately, fetal demise. Now, if things progress to the second and third trimester, if you take a look here, a lot of these findings overlapped with trisomy 13. I feel like they're about the same, especially with the two vessel cord, the low set ears, whole and proencephaly. So as you see, and we're going to discuss this later, how a lot of these markers kind of overlapped. And that's one of the challenges when you're trying to look at the markers and kind of correlate with them. But we'll talk about that in just a sec. And lastly, Klinefelter syndrome. I've only seen one screening result for this particular case, but everything ended up being okay. In this case, it's double XY, which you can see here. Okay, occurs only in males. Usually they're infertile due to the small testes in this particular case. Um, and a lot of there's I guess you can say people walking around that have this syndrome or didn't find out that they had this syndrome until adulthood because the prenatal screening wasn't around 20 years ago, 30 years ago, 40 years ago. And so with these prenatal screening results, it's able to pick this up, especially with these sex chromosome disorders. And so we're able to pick this up pretty early prior to delivery. Okay. All right, so I'm getting to the end. The steps in identifying these markers, you want to have some systematic evaluation, training, awareness within your department that really help with identifying these ultrasound markers. And so that's why I feel like ultrasound protocols are very, very important in these particular settings. Now, before we go there, the challenges that I was mentioning earlier were one of them are due to the overlapping characteristics. And so that's one of the challenges. Another one is the complexity of the ultrasound interpretation, because it kind of presents itself in different variations. And so it will lead to like a misdiagnosis and so forth. So these are just a few of the challenges, but I still feel like the benefits outweigh these challenges when it comes to offering other additional testing for the patient. Okay. All right. So let's just talk about these protocols. I feel like for each one, especially your first trimester screening, you should have a protocol in place, a consistent protocol, so you're able to consistently check for these markers early on. Because I feel like early diagnosis is key. And so I wanted to share with you an example of a first trimester screening protocol that we offer. We use this protocol standard for every patient, not just high risk, it's for every patient that has a first trimester screening. And so we're going through from head to toe and we're just checking off. Now, if anyone wants a copy of these protocols, just let me know. I will email them right over to you, because it's really important to follow some kind of protocol, especially in your first trimester screenings. And then here's an example of all the pictures that we are imaging for our level twos. Our level two exams are the 20-week scans. We're consistently taking all of these pictures consistently for every patient, low risk and high risk. Okay, and I'm happy to share these with you all as well. Okay, now the impact is tremendous. The impact with these ultrasound markers, as well as combining them with the screening tests, it's really impactful in prenatal care, and it's really making a difference, I must say. And so, if you see a positive screening with the ultrasound findings that connects the two, then it will lead to a maybe, a suggestion of having a additional testing to confirm the diagnosis is helpful. But also in the case where it's a false positive, everything looks good on the scan, but there's a positive result, but it kind of reassures the patient once you see baby looks fine. And I've actually seen that more than once, where baby looks fine and does not match with the screening result as well. Okay. Now the future. Where are we heading? Our machines are doing amazing things. Amazing things. Of course, with the 3D, 4D. This picture here is one of my favorite pictures, just where you can see early on the fetus, the amnion, the cord. I mean, our resolution with our machines are amazing now. And so we're able to pick up things that we weren't able to see 10 years ago. And so let's utilize this resolution to help identify these ultrasound markers. And so I want to just briefly show some things that are now you're able to do on your machines to help in in just recognizing these markers. And so the auto measurements is a feature that I personally love, and it helps kind of take your time away, so you're not measuring each one. Your machine is able to do it for you, and so it's so amazing to have that feature, which you can see here in the top two. Early on, this picture with the lung and the heart, this is a fetus that I believe was 10 weeks. 10 weeks I was able to pick up the pericardial effusion. Yeah. And then so down the bottom you can see a spina bifida. And I use standardly, like I said, we use 2D ultrasound, but I use 3D ultrasound just to enhance what I found on 2D, as well as the omphalocele here. I saw it 2D. I use my 5D here to get a good presentation of that omphalocele. Okay. And then just looking at heart. I love heart. I can just look at the heart all day. Here are some pictures just to enhance early on what you can see as far as heart defects, from the stick, changing your chroma, simply changing the setting, you can really see the valves there and so forth. Auto annotation, your MV flow. Just utilize these features so we're able to pick up those ultrasound markers that we've discussed. And that's it. So my conclusion is it's important, first and foremost, to improve our ultrasound findings, our technique in finding these ultrasound markers in order to be able to connect them with the screening results that the patients are now receiving. The advancements in the technology is making that easier for us sonographers in order to pick up these markers. And let's make it a dual approach with the prenatal screening, integrate it and help and with these diagnostics for the patients. I know it was a lot of information. I hope you were able to take a key takeaway from this lesson. I'm sorry I went over a little bit. It was just so much to talk about, but I'm all done. I'm all done, and I'm giving it back to you. Oh yeah,
Wow,
I hear you.
it's
I can stop.
amazing. Wow, thank you so much, Lachelle, for this
Absolutely.
stimulating presentation. Thank you so much for taking time out to go through all the aneuploidies and the correlations with the ultrasound findings and the
Hmm.
prenatal blood test as well. Um,
Hmm.
Just before I hand over to, I ask people for their questions. Just a quick question from me. Have you had
Mhm.
any, from your personal experience, have you had any situation where both were negative? I mean, ultrasound findings and the prenatal
Mhm.
blood test were negative, but baby still came out with something. Have you had such experience before?
Mm. I would say I have not seen that. But what I have seen is where a patient did not do prenatal screening,
Mhm.
okay, and the ultrasound was normal, and then baby had Downs.
Mm.
And so, it was settled, but baby I've seen that case before, where it was a positive Down syndrome, and so, of course, patients like, "Well, you missed it," but, it could be settled in that case for a Down syndrome, but it would be interesting to know what I think
Exactly.
prenatal screening would have picked that up, and then that's why I feel like it's still important to do, you know?
Absolutely.
Mhm,
Yeah. All right.
mhm.
Thank you. Thank you for
Yeah,
that.
sure,
Yeah.
sure.
So I'm going to encourage us to ask questions now. If you have a question, feel free to unmute your device and ask away, please.
Um, Hello.
Yes.
I think my question would be relative to the case you just shared now.
Mhm,
And that will be to draw from your experience, just relating to the communication aspect of that. Say a similar scenario where no prenatal testing and
mhm,
like you said, the scan comes out clean, but
mhm,
then at birth, there is an anomaly detected.
mhm,
Now, how would you approach that conversation, especially in a case where there is the obvious attempt to push the responsibility to the sonographer?
hmm,
And you have documentation of all the checks
mhm,
coming out as normal, but then there is
mhm,
still that communication of trying to get to push the blame, if I'll put it that way.
mhm.
So how would
Now
you approach that
mhm.
conversation?
To the sonographer,
Yes, to the sonographer.
I going back, I would say, because even in that particular case, I'm like, maybe it was a subtle sign on the ultrasound that possibly uh was missed, unfortunately. And you have to think, I didn't get to go back to look, but maybe there was a case of renal polyectasis
Okay.
or echogenic bowel that further on, you're, especially if it resolved, you're like, oh, it's fine, but maybe those were clues to maybe look further or even offer the testing. But I feel like at a certain point, once you get to like your 20-week mark, they don't necessarily push the screening test any longer, and so we just follow what we find on ultrasound. um, and then
Okay.
if it resolves, it resolves. But it's interesting. I wish I would have looked back, but I didn't get a chance to look to see if there was subtle signs that were there, and it just might have gotten overlooked, unfortunately, because that could have been the case.
Okay.
Yeah, but I would just, it's just still helpful to pick up still. I tell a lot of my students, if you see something, don't say, "Oh, I'm making that up." A lot of times my students aren't as confident to call it. And so I'm like, "No, if you question something, just bring it to the
Great.
doctor's attention." Absolutely. And so have them take a further look, in those cases. Yeah.
Okay. Thank you.
Yeah, no problem. Mhm,
Thank you. So
Okay.
mhm.
just to remind us all, if you have a question, you can also type it in the chat box.
On
I'll
the
read it
chat?
out. Yes, if you don't want to.
Okay, please, I have a question.
Sure.
Okay, I know there are some situations where the blood test will come out with low risk. But
Mhm,
on the ultrasound scan, for instance, you are measuring NT, and
mm,
it's obvious the NT is above normal range, which is an indication of an anomaly, but the blood came back with low risk. So what are the
mhm.
structures are you looking out to further follow up in terms of the baby?
Absolutely. Even in those cases where it don't match, I've seen the doctor recommend additional ultrasounds. They always say because potentially things could come up even in the third trimester, which I've seen. I've seen where there was a normal uh screening but absent nasal bone and a thickened nuchal. I'm like, what? Like, I don't get that, you know. But we followed that case. She came back for a genetic scan. She did a level 2. She even did a fetal echo, and things end up being fine. And even as the baby got bigger, the nasal bone, you start to see it was small. It was there, but we couldn't see it because it was just so early on, but it was just really small. And of course the nuchal resolved, so it wasn't as thick later on, and baby was fine. But we saw that in those additional ultrasounds that we offered to the patient.
Okay, thank you.
Hmm. Hmm.
Okay.
Thank you. Do we have any
Yeah,
more questions?
I'm looking through the chat to see if there. Oh, can we get the slide? Oh, you guys, so someone wants the slides from the presentation. Yeah, I'm happy to share. Um, if you leave your email address, I can email them to you. I guess it's
So
Alfred
we could,
was asking about the
mm,
slides. Or is there a way I could share? Like, how could
yeah,
I?
so
Because
we
I don't
have like
mind.
an email list for all the registrants, which we can send to them.
Oh,
Mm.
okay,
Yeah, we can
okay,
send it there.
sure. Yeah, I'm happy to share. I'm happy to share the
Thank you.
slides. Mm-hmm.
Thank you for that.
Hmm. Yeah, absolutely. See, I'm just going through.
Okay.
Oh yeah, someone else is asking about the slides. I'm just going through, and then I have some that want a copy of the protocols
Of the
too.
protocols, and there was a
Hmm.
screenshot earlier on as well. The
Yes,
one about the
yes,
risk.
yes,
Mhm.
yes. Okay,
Right.
Please, I have a question, please.
sure, sure.
Okay. My question borders around communication to the parent,
Mm-hmm.
the mother, in terms of suspicious findings. Sometimes the patients, even though when you've explained a particular possibility of an outcome,
Mm-hmm.
at the same time of referring them for further checks, maybe with a fetal medicine specialist, and also testing, they will keep asking questions. Now, you don't
Mm-hmm.
want to give them a diagnosis that is not, you're not sure, which you
Mm-hmm.
need uh, further testing for them to confirm that. And at the same time, you don't want to give her assurance that what you're saying
Right,
is nothing.
right.
So how do you balance it? Because they immediately you tell them that you're saying something, they become tensed already, and then they begin to ask a lot of questions, uh,
Mm-hmm.
trying to make you, assure them or tell them that something is wrong, which you
Mm-hmm.
don't want to, conclude at that point.
Right. At my facility, we we're not even allowed to, as the sonographer, we're not allowed to even say yay or nay as far as what we're seeing. And so, which I find that's easier for me, especially in a case where there is a abnormal ultrasound. Um, because I'm not allowed to say anything at the end of my scan, because of course they ask, "Oh, how's everything? Oh, how's baby?" Oh, the doctor will be in, and and it falls on the medical doctor, which are they're the ones that can diagnose and go further into testing. Now, you have some patients that keep asking, or they know that there is something wrong, and they're like, okay, you're not telling me, you're lying to me. Sometimes they're rude like that, and I'm just like, ma'am, it's not my job title. I'm sorry, I can't go any further. Let me go grab the doctor, or let me grab the genetic counselor. They'll be right in to talk with you. I'm so sorry. This is just as far as I can go. I'm just a picture taker. A lot of times I say that, and a lot of times they're like, okay, and I'm like, they're coming right in behind me, and they're going to answer all of your questions. And so that's how I usually get away with not saying too much to a patient, which is easier. I find it's easier for me.
Okay. Just to add to what
Hmm.
Lachelle said, I don't
Hmm.
think I think there's a limit to what you can see really until the
Hmm.
definitive test is done. Yes, even the
Yeah.
doctor won't say anything definitive until they've carried out their test and they are really sure. So even though they might be disappointed because they're wanting more information, but I believe that deep down they understand that you really can't say more than that at the moment. Yes.
Yeah. Hmm. Absolutely.
Okay. Thank you very much. That's clear enough.
Hmm.
All right.
So
Thank you.
you're welcome.
Okay, so we have a question in the chat box from Hetia. Says, thanks for the presentation. I wanted to ask if there's any effect to the fetus caused by pulsed wave Doppler in early first trimester, measuring heart rate, and also when is it suitable to use Doppler scan in obstetrics ultrasound?
Now, early on, we do not utilize the pulse Doppler because of the risk, but in the case of like for that trisomy 21, we briefly used it and to help in with the diagnosis. It was a brief, just to help in that particular case, but it's not something that's like a standard, only because of the risk that it carries. Now, far as further on, as long as you stay in your alara, which we know alara as low as reasonably achievable, on your machine, it has those parameters set. So as long as you stay within those safety parameters, you should be fine, far as the Doppler settings later on. But yeah, in the first trimester, we really try to abstain from using the pulse wave Doppler.
Thank you, Lachelle.
Mm-hmm.
Hussein is asking, what approaches does a sonographer use to implement scanning protocols and also
Mm-hmm.
take professional responsibility in relation to reporting?
Mm-hmm. Um, Meaning, I guess, are they asking like far as following that protocol, like for the first
Yes,
trimester screening?
yes,
We
indeed.
we set it in place, and I know some might look at that protocol and like, man, that is so much pictures. And you want to know the reason why we have that long protocol is because we missed a few things and we weren't routinely looking. And so it increased our protocol over time. And so we find what we have in place now are pretty much all the parameters, checklists for that fetus profile. And so that's why that protocol is set in place. And I tell you, from that first trimester screening even to the level 2 ultrasound, that protocol has been so helpful in recognizing these markers. Oh, I think it's muted. It's muted. There we
Okay,
go.
no. Thank you so much, Lachelle.
Mhm,
Okay, so I think that we can round up now in the absence
mhm,
of any further questions. So I would like to say a very big thank you to Lachelle for an insightful and thought-provoking presentation. Honestly, your depth of experience and the clarity with which you're presented today, honestly, has added great value to each and every one of us today. Thank you so much. And to
you're welcome.
everyone that has attended, thank you for being part of this learning experience. Your
Mhm,
questions reflect your passion and professionalism that continues to drive excellence in prenatal care and ultrasound. So we hope that today's session has inspired you to reflect further on the evolving role of ultrasound in early detection and decision-making around chromosomal abnormalities. And on that note, we look forward to welcoming you again in our future sessions. I wish you all a great rest of your day, and thank you once again, and goodbye. So just before we say goodbye, finally, can I request that we all unmute our device, please? Please, if you don't mind, can you all unmute your device? I want us to all say a very big thank you to Lachelle. We're going to be saying it in a big chorus.
Thank you, Lachelle.
Are we ready?
Thank you, Lachelle.
Thank you,
For the
Lachelle. Thank
thank
you.
you. So one moment.
Thank you, Lachelle. Thank you.
Okay,
Thank you,
let's say
Masha.
it
Thank you.
together.
Thank you,
In
Lachelle.
three, go.
Thank you,
Thank you, Lachelle. Thank you so much.
Thank you
We are
very
so
much.
grateful for this time. Thank you so much.
So much.
Thank you. Thank you, everyone. Have a beautiful
Thank you.
day, everyone.
Thank you.
Bye.
Thank you. Bye.
Thank
Thank you.
you. Thank you, everyone. Yeah.
Will I have a copy of the chat so I can be able to send